So today let's start some other topics on neonatology. Let me see whether just 2 minutes. Yes, done. It has come. Okay, let's start the show. What is the question for today's discussion? Discuss the neonatal thermoregulation by addressing the following points. One, source of heat loss in newborn. Second point, source of heat production. Right. Source of heat production and physiological response to hypothermia. Prevention of hypothermia, including the steps in warm chain. Clinical features of hypothermia in newborn and management of hypothermia. So, management of neonatal hypothermia. So, these are all the questions that we are going to discuss right now. Remember, temperature regulation is the cornerstone in any neonatal management, and definitely you will be asking questions not only with respect to essay but also with respect to short notes. And let me cover some of the important MCQ points with respect to NEET next or in your Viva OC. Right. First, so neonatal thermoregulation. What can anyone tell me what is the normal newborn temperature? Normal newborn temperature. So the normal newborn temperature is, what is the normal newborn temperature? Now, the normal newborn temperature is 36.5 degrees Celsius to 37.5 degrees Celsius. This is the normal newborn temperature. Okay, point number one. When you have a temperature of more than 37.5 degrees Celsius, it is called hyperthermia. It is called hyperthermia. When you have a temperature of less than 36.5 degrees Celsius, it is called hypothermia. Hypothermia. Remember, whenever you have any infection, invariably the manifestation of infection in pediatric age group is fever. So it means fever equal to infection. But in newborn, the reverse is true. The most common manifestation of sepsis is hypothermia. Infection is equal to hypothermia in newborn. This is very, 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 very important. Okay, infection is equal to hypothermia. Only two note, chinna note. Only two infections can produce fever. Can anyone tell me what are all the two infections that can produce fever in newborn? Only two infections. What are all they? One is herpes simplex. The second one is malaria. Excluding these two, no other infection will produce fever in newborn. Majority of them will produce hypothermia rather than hyperthermia. So next point, another point. Okay, what is called mild hypothermia? So then hypothermia means less than 36.5 degree Celsius is equal to hypothermia. Hypothermia. And this hypothermia can be classified as mild, moderate, and then severe hypothermia. What is called mild hypothermia? Mild hypothermia, very, very important, 36 to 36.4 degrees Celsius. So the range is very, very narrow. This is called mild hypothermia. Remember, one question they can ask you is, this is called cold injury, otherwise known as cold stress. Otherwise known as cold stress. And remember how to identify it. Keep one hand over the abdomen and another hand over the foot. When hand over the abdomen is warm and hand over the foot is cold, means this is called hypothermia. This is called cold injury or cold stress. I repeat. So hand over abdomen is warm and hand over foot is cold. This is called hypothermia. This is called hypothermia, the first manifestation of any sepsis. Okay, second one, what is called moderate hypothermia? Moderate hypothermia is 32 degrees Celsius to 35.9 degrees Celsius. This is called moderate hypothermia. What is called severe hypothermia? Less than 32 degrees Celsius is called as severe hypothermia. Degrees Celsius is called as severe hypothermia. Remember, this is very important. Among this, what are all the questions that you are not supposed to miss? This point. Cold injury or cold stress is defined as a temperature between 36 to 36.5 degrees Celsius. When in Viva OC, if you are asked how to find out, the hand over the abdomen will be cold and hand that is kept over the foot will be, hand over the abdomen will be warm and hand over the foot will be cold. So there is a temperature difference, there is a core peripheral gap. This is called cold injury or cold stress. Why I am stressing it again and again? The answer is very simple. The answer is very simple because you need to identify it and it is frequently asked question. Second one, it is not hyperthermia that is the manifestation of sepsis. It is hypothermia that is the manifestation of sepsis in newborn. Only two infections will cause hyperthermia. One is herpes, second one is malaria. Right? Second one is malaria. Okay. Right. So this is with respect to temperature differences. And then what are all the other questions that can be asked? Very easy. What are all the other things they will ask you? What is called neonates? Whenever you feel cold, you will have rigor. Rigor is nothing but what? Shivering contraction of the muscles. As a result of contractions of the skeletal muscle, your body gets warmed up. But newborn baby doesn't have good skeletal muscle. As a result of it, it is not shivering that leads to increase in heat. That is, but here it is replaced by non-shivering thermogenesis. Second, very important MCQ is non-shivering thermogenesis. How they will ask you, how does newborn baby maintains the temperature? Means the answer is very simple. It is non-shivering thermogenesis. Shivering thermogenesis. What is called non-shivering? As I told you, it lacks skeletal muscle. It is mediated through brown fat. Mediated through brown fat. Normal fat is yellow in color. This brown fat is brown in color. It is present in nape of neck. It is present in axilla. It is present over the kidney. And it is present in interscapular area. It is present in interscapular area. These are all the areas where this brown fat is present. Second point. Third point, which mediates this brown fat? This is another important question. Norepinephrine. Which one? Norepinephrine is the one which is responsible for this non-shivering thermogenesis. It causes uncoupling of beta oxidation. It causes uncoupling of beta oxidation. What is called uncoupling of beta oxidation? What will happen? Here, beta oxidation, uncoupling of beta oxidation leads to increased heat production. Leads to heat production rather than ATP production. Leads to increased heat production. So again, this is a very important short notes. Non-shivering thermogenesis again itself is an important short notes. Your preterm, your small for gestational age baby has less brown fat and more prone for hypothermia. So this is all about brown fat. This is all about brown fat. This is all about non-shivering thermogenesis. Just 5 points. Brown fat, where it is present, which A neurotransmitter, it is mediated through, it is often asked Ames question. What happens here? Uncoupling of beta oxidation, where it instead of ATP, a heat will be produced, and preterm and small for gestational age are prone to develop because they have less brown fat. Right? So, as far as temperature regulation is concerned, these things are very, 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 very important. Now, let's go to the other things. What are all the ways by which you will lose your heat? Okay, why newborn is prone to lose their temperature? The answer is very simple. Why newborns are prone to lose their temperature? It can lose temperature in four ways. One is evaporation. What is evaporation? With the help of sweat. Okay, whenever the sweat that is present over the newborn can get evaporated. As a result of which you can lose your body temperature. Second one is conduction. How does you lose your heat by means of conduction? Nothing but contact. Whenever, as I told you already in my previous class, you need to receive the baby in a pre-warmed towel. Whenever you use a cold towel and you receive the baby, what will happen? That cold towel in turn absorbs the temperature of the newborn that is in contact with the baby. So conduction means contact with the cooler surfaces. Conduction. Third one is radiation. What happens in radiation? You lose your temperature because of the cooler surfaces. So it is without contact, cooler environment. So it occurs without contact. So conduction, convection, radiation, and then convection. What is called convection? So convection means it is through atmospheric air. So there are four modes by which you can lose your heat: evaporation through sweat, conduction in contact plus, radiation without contact minus. Convection is due to airflow, cool airflow around the child's atmosphere. Right. Next point. So these are all the ways by which you lose your temperature. Right. Then how does a radiant warmer works? Radiant warmers works based on the principle of radiation. Radiant warmer works with the principle of radiation. How does convection works? In which mode uses this convection to increase the temperature of the baby? Very good. Incubator. What? Incubator. Incubator is the one which operates through convection. So these are all the four modes by which you lose your you gain your heat. Either you can lose your heat if the contact surface is cold, but when you have a warmer above you, you can get temperature from the warmer without any contact. Right. So what are all the various temperature? What is hyperthermia? What is hypothermia? What is called cold injury? Non-shivering thermogenesis is a short notes. Four modes by which you lose your temperature is a short notes. They themselves are a short notes, right? Okay, so evaporation, conduction, convection, radiation explained. Brown adipose tissue explained. Apart from brown adipose tissue, there will be a generalized vasoconstriction and it is mediated through norepinephrine. How to prevent hypothermia means very, very simple. Warm delivery room, and this is an important entrance MCQ. Look at this. Your delivery room temperature should be maintained in and around 25 degrees Celsius. I repeat, your delivery room temperature should be maintained at around 25 degrees Celsius. And immediate drying. You all know that the child will be having some kind of amniotic fluid or liquor over the body. So when you don't dry the body immediately after birth, this liquor will evaporate, and as a result of which you lose your temperature and you are prone for hypothermic if you don't clear this, dry the baby. Okay, skin to skin contact. You all know that Kangaroo mother care promotes breastfeeding as well as increases the warmth of the baby, increases the breathing of the baby also. So prevention of hypothermia is mainly meant by means of one, maintaining the delivery room temperature. Second one is drying the baby immediately. Third one is skin to skin contact. Okay, then breastfeeding, as I told you already. Whenever any child is born less than 2.5 kgs, they are more prone for hypothermia, as a result of which we advise them till the child gains 2.5 kgs, better not to bath the baby. Appropriate clothing and bedding. So, what do you mean by that? In a cold temperature like this, whenever any child born during this October, November, December, we need to give so much of importance to, just you need to cover the baby's body with a shawl, you need to wear gloves, you need to wear socks, and you need to wear mitten over the head. So if each and every part of the body should be covered properly to maintain the temperature. Warm transport, the name itself indirectly says you need to transfer the child either under the warmer or in the incubator, and each and everyone in the particular unit should be trained properly, right? Mild hypothermia, it was explained an MCQ. Okay, moderate hypothermia and poor and severe hypothermia, they are not MCQs, so this is an MCQ. But whenever any child is had attained, has gone for moderate or severe hypothermia, what will happen as a result of which? Heart rate bradycardia will come. Bradycardia will come. Slowly, the child will be lethargic, comatose, and finally, the child will be having some kind of respiratory distress. So, the most common manifestation of hypothermia is one, to start with, decreased activity, lethargy, and poor feeding, and it is followed by bradycardia. Bradycardia is a manifestation of not only hypoxia, but it is also a manifestation of hypothermia. Very, very important. Okay, what is the management? Mild hypothermia, you need to ask the patient to wear gloves, bulla, socks, everything, mittens. All along with that, you need to encourage the mother to have skin to skin contact. But as far as moderate hypothermia is concerned, you need to use a radiant warmer. Here, mother temperature alone will not be sufficient. So you need to use a radiant warmer or incubator. Okay. Preterm, lesser the term, preterm means more prone for hypothermia. Better to keep in an incubator so that it cannot be contaminated by the drug resistant organism that is present in the environment. Okay, so what is the ideal rate of increase of temperature? Again, this is a question. So you need to increase the temperature 0.5 to 1 degree Celsius per hour. Slow increase in temperature. But as far as severe hypothermia is concerned, the baby will have bradycardia, baby will have hypotension, baby will have lethargy and poor feeds. Along with that, the metabolism will decrease, leading on to lactic acidosis. Lactic acidosis. Again, they are more prone for hypoglycemia. So, what do you mean by that? Apart from keeping the child under a radiant warmer or an incubator, you need to give dextrose solution. Again, you need to remember that severe hypothermia can be a manifestation of sepsis. As a result of which, all children with severe sepsis should be severe hypothermia should be started on antibiotic unless otherwise proved, along with sugar correction. Okay, very, very important. Severe hypothermia should be considered for underlying infection and you need to start antibiotic, right? That's it. So our first question is over. Right? First question is mainly concentrated on temperature regulation of the baby. Okay, now the second question is explain the procedure of kangaroo mother care. The second question is explain the procedure of kangaroo mother care. You all know that. So first question is over. First question we had completed. What about the second question? The second question is we need to concentrate on the explain the procedure of kangaroo mother care. We all know that kangaroo, it doesn't mean that only mother as can give kangaroo mother care. Anyone, including father, grandmother, grandpa, anyone can give kangaroo mother care provided if they are willing to do. Okay, then. So what happens to in this kangaroo mother care? By keeping the baby in between the breast in the over the chest, the temperature of the baby will be increased by means of conduction. Temperature of the baby increases by means of conduction, and also you are simultaneously stimulating the baby to have breastfeeding. This is how your kangaroo mother care works. Remember, kangaroo mother care is detected by a male, not by a female, and the person name is called Edgar Ray. And the person name is called Edgar Ray. Kangaroo mother care name is called Edgar Ray. This is very, very important. So mainly term babies usually do not require kangaroo mother care. Kangaroo mother care is mainly for preterm or low birth weight babies, particularly those who are weighing less than 2500 grams, and particularly babies who are less than 37 weeks of gestational age. Younger the child, more the importance of kangaroo mother care. The only one principle is skin to skin contact. So preterm, low birth weight are the entry level criteria. Second point, someone has to be willing to do skin to skin contact, preferably mother. Okay, and then what are all the key features? It can be started as early as possible after birth. By giving a kangaroo mother care, the child's head is close to the breast, as a result of which exclusive breastfeeding can be promoted, not only in hospital but it can also be done at home. Okay, as far as possible, we avoid children as soon as possible. Any preterm who starts weighing and who is taking feeds on her own, we will discharge the child to prevent nosocomial infection. Right? Again, what are all the other points that you need to know? What are all the other points you need to know? Remember, kangaroo mother care can be started immediately when the child weight is more than 1800 grams. I repeat, kangaroo mother care can be started immediately when the child is weighing more than 1800 grams. But when the child is less than 1200 grams, it might not be possible to hold that small child to keep in the chest between the breast. It may slip and fall. So less than 200 grams may take weeks before kangaroo mother care can be started. Until then, you can put the child under radiant warmer or incubator. Whereas in between 1200 to 1800, it may take a few days to start kangaroo mother care. So less than 200 grams will take some weeks to start kangaroo mother care. 1200 to 1800 will take only few days to start kangaroo mother care. Then people will be asking you when kangaroo mother care can be started immediately after birth. When the child is weighing between 1800 to 2500 grams, you can start kangaroo mother care on the day of birth itself, provided to prevent the child from getting hypothermia. Right. Remember, one, the child should not have any sepsis, the child should not have any respiratory distress, the child should not have any shock. So only hemodynamically stable babies are eligible for this kangaroo mother care. So what is the procedure of the procedure of kangaroo mother care? This is often asked question either as a short notes or in the Viva OC, skin to skin contact. So it is basically meant, it is basically the principle behind is the mother can give heat to the baby through what? Contact in surface, that is conduction. Remember, place the baby upright against the mother's bare chest. Remember one more thing. It is skin to skin contact, not skin to dress contact or not dress to dress contact. So both baby and the mother should be in bare body. Okay, at least bare area of chest indeed. One, so bare chest, first point. Second point, head position. The head should be turned to one side and slightly extended to keep the airway clear. So head should be turned to one side and keep up. So that means what? It is nothing but a modified sniffing position in supine posture. Neck and back support. So you need to put a proper neck and back support snugly against the mother's chest wall. Okay, it should be snugly against the mother chest wall, well supported. The baby's neck and body should be well supported against the bare chest. And then legs and arms position. So legs should be flexed and slightly abducted. Legs should be flexed and slightly abducted, spread apart, and arms should be flexed in a comfortable neutral position. You all know that universal posture after the birth is both flexion of upper and lower limbs. So in the same way, both upper limb and lower limb should be in a flexural posture over the chest. Flexural posture over the chest with minimal abduction so that it can accommodate the mother's tummy. Clothing and covering. Okay, dress the baby only in diaper area. This is very, very important. Dress the baby only in diaper area and with the mother's clothing or light blanket to maintain warmth. Diaper area alone should be closed. What is the mother's position? Mother should be in a semi-reclined position. Mother should be in a semi-reclined position with a support. And finally, monitoring. Always the child who is under kangaroo mother care should be watched for breathing, color and temperature. Breathing, color and temperature. When the child is more than 2500 grams, when the child is more than 37 weeks of gestational age, you can stop giving the kangaroo mother care. The child will be on its own. I repeat, the child will be on its own. You need not worry about this kangaroo mother care when the child is more than 37 weeks of gestational age or more than 2500 grams. So what are all the key points that you need to know in this? What are all the key points? Point number 1. So now let me tell you about some minimum 10 points to remember to write a short notes or an essay. So based on that you can develop your story writing. Point number 1, skin to skin contact. Point number 2, mother should be in bare chest. Point number 3, the child should wear only napkin. Point number 3. Point number 4, mother should be in a semi-reclined posture. Point number 5, baby should be in the should be over the mother's chest with flexed upper arm and flexed as well as abducted lower arm. Head should be turned to one side and extended up so that trachea, nose and nasopharynx will be in a straight line. Less than 200 grams baby when the child is born may take few weeks to start KMC. 1200 to 1800 grams, 1200 to 1800 grams you may need to wait for only few days to start kangaroo mother care, whereas kangaroo mother care can be immediately started when the child is more than 1800 grams. When to withdraw kangaroo mother care? When the child is more than 37 weeks of gestational age or attained 2500 grams, kangaroo mother care can be stopped. Remember, even when the child is on kangaroo mother care, the child should be hemodynamically stable and also the child should be watched for color difference, temperature difference and breathing pattern, because when you have problems with this things, the child is said to be an immunodynamically compromised and you need to stop kangaroo mother care and you need to put the child on radiant warmer or incubator under your care, right? So these are all the points that are very, very important with respect to kangaroo mother care, the 10 points that I have told you. And one more point, by putting the child in kangaroo mother care position, you are indirectly stimulating the baby to start to go for exclusive breastfeeding. To go for exclusive breastfeeding, remember, it is invented by a person called Edgar Ray. So non-shivering thermogenesis over how the baby loses its temperature over. Third point is what are all the various type of temperature differences, 32 to 36, 36 to 36.5 we have learned. What is called cold injury or cold stress and how to maintain the temperature of the baby, and what is the room temperature for the delivery, 25 to 28 degrees Celsius. That's it. So first question over, second question kangaroo mother care over. It is also related to hypothermia only. Remember, mild hypothermia, warmer is enough. Moderate warmer is enough. Sorry, kangaroo mother care is enough. Moderate hypothermia, you need to go for radiant warmer or incubator. Severe hypothermia require shock correction and antibiotic, because I am saying severe hypothermia again is a reflection of infection. Also, in newborn, hypothermia is equal to infection. In children, fever is equal to infection. But in newborn, only two infections that can produce fever. One is herpes, another is malaria. Another is malaria. Okay, done. Another is malaria. Okay, next question. Okay? Right. The next question is, write a short notes on neonatal seizures. Tabulate the differences between jitteriness and seizures. Tabulate the differences between jitteriness and seizures. Okay. Differences between the jitteriness and seizures. So let me explain you. Okay. So what are all the types of seizures? Remember, seizure will be associated with the bradycardia and cyanosis. I repeat, seizure will be associated with bradycardia and cyanosis. Point number one. What are all the types of seizure? The first type of seizure is called subtle seizure. What is the seizure is called? Subtle seizure. What is this subtle seizure? Subtle seizure. What is this subtle seizure? Subtle seizure means the child will be having lip smacking, lip smacking. The child will have roving movement. The child will have pedaling movement. So this lip smacking, rolling of lip smacking, pedaling, roving movements are called subtle seizure, and it is the most common seizures. Very very important. So subtle seizure is the most common seizures, and the most common cause is birth asphyxia. The most common cause is birth asphyxia. As I told you already, lip smacking. So one is lip smacking. Second one is roving movement of upper limb, pedaling movement of lower limb. This is called subtle seizure. So the second one is tonic seizure. Second one is tonic seizure. Tonic seizure means sustained contraction of muscles. I repeat, sustained contraction of muscle. This is called tonic seizure. Most commonly it occurs in intraventricular hemorrhage. Intraventricular hemorrhage in preterm babies. In preterm babies. Second point, preterm babies. Second. Third one is tonic. Third one is clonic seizures. Third one is clonic seizures. Clonic seizure means it is rhythmic contraction and relaxation. Rhythmic contraction and relaxation. That is tonic-clonic seizures. Clonic seizures means, as I told you, it is rhythmic contraction and relaxation. Clonic seizure. Remember, the most common manifestation of a clonic seizure is, okay, what is the manifestation? Neonatal stroke. Very, very important. Neonatal stroke. Okay, neonatal stroke as well as hypocalcemia. These are all the things that can cause clonic seizures. And finally, finally, what is this? This is called myoclonic seizures. This is called myoclonic seizures. Remember, myoclonic seizure is a manifestation of inborn errors of metabolism. Myoclonic seizures is a feature of inborn errors of metabolism. Which one? Myoclonic seizures. So these are all the four types of seizures. I repeat, these are all the four types of seizures. Okay, and then these are all the four types of seizures. And then what are all the causes for seizures? The causes for seizure is, one is hypoglycemia. What are all the causes for seizure? One is hypoglycemia. Hypoglycemia, low sugar. Second one is hypocalcemia. Second one is hypocalcemia. Okay, always these things to be needs to be given importance. Third one is another electrolyte, hypomagnesemia. Hypomagnesemia. In children with some severe birth asphyxia, there are chances for you to get hyponatremia. So these are all the electrolytes that are responsible for causing seizures in newborn. Second one is meningitis. Second one is meningitis. Third one is torch infection. Fourth one is intraventricular hemorrhage, bleeding in preterm. That is particularly in preterm. Which one? Intraventricular hemorrhage. So third cause. So these are meningitis, torch, and then cranial malformations. Cranial malformations. Can anyone tell me one cranial malformation that can lead to intractable seizures in newborns? Can anyone tell me only one? One cause, schizencephaly. What? Schizencephaly. What is called schizencephaly? A slice of brain will be absent, as if you are removing a piece of watermelon from full watermelon. Now, in the same way, a piece of brain will be missing. A piece of brain will be missing at birth, and it can lead to intractable seizures. So this is meningitis, starch infection, IVH, cranial malformation, schizencephaly. But when all these things are absent, you screen for all these things, but it turned out to be absent. Think about benign fifth day neonatal convulsion. Benign fifth day neonatal convulsion. Fifth day neonatal convulsion. Can anyone tell me what it is due to? The fifth day neonatal convulsions benign is due to very important low CSF zinc levels. Low CSF zinc levels. And another cause for neonatal seizures, in which CSF glucose is always low. CSF glucose is always low. So in which condition CSF glucose is always low? Remember, glucose transporter 1 deficiency. Very important. Glucose transporter 1 deficiency. Glucose transporter is the one which is present across the blood-brain barrier. When this glucose 1 transporter is absent, sugar cannot reach the cerebrospinal fluid. So any intractable seizures along with the persistent CSF low glucose is nothing but a manifestation of glucose transporter 1 deficiency. Glucose transporter 1 deficiency. And another most important point is, whenever any child develops intractable seizure, the last sort of effort is giving pyridoxine. So low pyridoxine can also be lead to intractable seizure in newborn. You all know that excitatory neurotransmitter is glycine, aspartate and glutamate, whereas inhibitory neurotransmitter is GABA. This GABA production requires pyridoxine. So when pyridoxine is low, GABA will be low. Pyridoxine is low, GABA will be low. So the shift will be tilted to excitation, leading to intrauterine seizures. So then they will ask you, what is the condition that can produce intrauterine seizures? The one which can produce intrauterine seizure, that is seizure even when the child is being in the fetal stage itself. You must be thinking that the child is kicking the mother's abdomen from inside like anything, but it is usually a case of intrauterine seizures. So exaggerated fetal movement is nothing but pyridoxine deficiency manifesting as intrauterine seizures. Another thing is glycine encephalopathy. What? Glycine encephalopathy. So in which the glycine will not be metabolized, and glycine above the level of, you must be thinking that, hey, glycine is an inhibitory neurotransmitter. The answer is no. Glycine above the brainstem is excitotoxic and below the brainstem is inhibitory. So in glycine encephalopathy is a condition in which the glycine levels will be very high in the CSF, leading on to excitation and seizures. So what are all the things you need to discuss in case of neonatal seizure? The four types are subtle seizure, tonic seizure, clonic seizures, myoclonic seizures. Electrolytic disturbances like hypoglycemia, calcemia, magnesemia, hyponatremia. Infections like TARCH, meningitis, intraventricular hemorrhage, cranial malformations. Low CSF zinc levels leads to benign fifth day neonatal convulsion. Persistent low CSF glucose in the presence of normal blood glucose is suggestive of glucose 1 transporter deficiency. Reduced pyridoxine can lead to intrauterine seizures. More the glycine leads also due to intrauterine seizures. Remember, what is the most common cause for seizure? The most common type of seizure is subtle seizure, and it has got the best prognosis. And most common cause for seizure is birth asphyxia. Birth asphyxia is the most common cause for seizures. So all other things were discussed, and these neonatal seizures can be managed with, first you need to presume that the child is having hypoglycemia, give 2 ml per kg of 10% dextrose, wait for about 2 minutes. If the child seizure doesn't stop, give 2% 2 ml per kg of calcium gluconate. If the child is still convulsing like anything, you can start phenobarbital. If the phenobarbital doesn't work, you can go for phenytoin. If phenytoin doesn't work, then midazolam drip can be started. Midazolam drip can be started. So this is all about neonatal seizures. All about neonatal seizures. Then the mother will be saying, "Doctor, you please come and see my child, doctor. The child is having some like a movement, doctor." So it is okay, it is just having some kind of movement like this. So what is this? It is nothing but jitteriness. Remember, jitteriness is involuntary shaking of many with a tremor like action involving the upper and the lower limb, predominantly upper limb. It can be usually due to underlying hypoglycemia, or it can be due to hypocalcemia. So any child who is showing frequent jitters, we usually correct hypoglycemia and hypoglycemia and then hypocalcemia. These two things has to be ruled out. Remember, whenever the child is having jitteriness, you can stop by holding the hand of the child. So if you are able to stop the movement, then it is jitteriness. But in case of seizures, you can't stop the hand which is convulsing. Very, very, very important. And remember, while the child is having jitteriness, the child will be alert and active. But whenever there is a seizure-like condition, whether it is subtle seizure, tonic, clonic, or myoclonic, obviously the mentation will be affected, leading on to what? Poor lethargy, altered consciousness. Okay, altered consciousness. And remember, always your true seizures will be associated with autonomic changes like a tachycardia, or a hypertension, or sweating, or increased frothing from saliva. These things are absent in case of jitteriness. I repeat, jitteriness is triggered by stimuli and can be stopped. It is tremor like movement. The baby is almost always alert and responsive, and it can be stopped by holding the affected limb. Second point, no associated autonomic changes. Whereas seizures can occur spontaneously. There are so many reasons which was mentioned in the previous slide. Here also it can produce repetitive jerking, but this will be associated with altered consciousness and decreased responsiveness. Even when you hold the baby's hand, the true seizure will not stop, and it is associated with autonomic disturbances like apnea, cyanosis, bradycardia, etc. So this is all about. First one is what are all the causes for neonatal seizures. Second one is what are all the types of neonatal seizure. Third one is how to differentiate between jitteriness and neonatal seizure, true neonatal seizures, without doing any investigation. Right? The next question. So what is the next question? So we have completed so many things today, and now let us come to necrotizing enterocolitis. So what do you mean by this necrotizing enterocolitis? Necrotizing enterocolitis is nothing but necrosis of the intestinal lumen. I repeat, it is nothing but the necrosis of the intestinal lumen. As a result of necrosis of the intestinal lumen, the intestinal air will go and fetch the place inside the intestinal wall, and this is called nematosis intestinalis. What is this? This is called nematosis intestinalis. Air filled pockets in the intestine is called nematosis intestinalis. Okay, nematosis intestinalis. Now the people will be asking you, what is necrotizing colitis? As I told you already, it is nothing but the necrosis of the intestine, particularly small intestine, particularly ileum and cecum. cecum. So what is the classification? And remember, your necrotizing enterocolitis will not come immediately within a day by not keeping the baby under the radiant warmer or incubator. Usually it sets over a period of 2 to 4 weeks. So whenever any child with a brought with a sudden onset abdominal distension within a day or two, and before 2 days the child is absolutely eating, means it is unlikely be due to a case of necrotizing enterocolitis. Unlikely be due to a case of necrotizing enterocolitis, right? So what are all the predisposing factor? So let me tell first. So remember, whenever you have preterm, what is the most common predisposing factor? Most common predisposing factor is preterm. And usually these preterm are more prone for infections. Preterm, and they are more prone for infections. And remember, when you start giving non-breastfeed or formula feeds, or formula feeds, it is a risk factor. I repeat, first one is preterm itself is an indication. Preterm itself is a risk factor for necrotizing enterocolitis, followed by presence of infection, and followed by giving things that is not breast milk. These three things can contribute to necrotizing enterocolitis. Okay, so this is the triad of etiology. Now triad of manifestation. The first and foremost manifestation of necrotizing enterocolitis is dash. Can anyone tell me the first and foremost thing that necrotizing, when will you suspect necrotizing enterocolitis? Can anyone tell me when you will be suspecting necrotizing enterocolitis? When? Tell me. So you are just handling a preterm baby. The preterm baby suddenly develops dash. So when it suddenly developed a dash, you will consider in terms of a underlying necrotizing enterocolitis. What is the most common manifestation? The most common manifestation is, tell me, what is the most common manifestation? The most common manifestation is abdominal distension. So the most common manifestation is abdominal, not abnormal, abdominal distension. So is abdominal distension. Second one is, because of abdominal distension, the stomach goes for gastric paresis. So when the stomach doesn't propel, what will happen? Feeding intolerance. Feeding intolerance. Third one, the doctor will say you do stool for occult blood. You stool for occult blood. So the simple investigation of choice is stool for occult blood. So abdominal distension, gastric paresis leading to frequent vomiting, and stool for occult blood will be positive. So and again usually divides into some stages. Stage 1, stage 2, and stage 3. Each stage is characterized by 2 groups: 1A, 1B, 2B, 2A, 2B, 3A, 3B. 3A, 3B. 3B. So this is called, what can anyone tell me what is this classification called as? Can anyone tell me what is this classification called as? This classification is called as modified Bell staging. What is this? This classification, I'm sorry, this classification is called modified Bell staging of necrotizing enterocolitis. Necrotizing enterocolitis, right? So as I told you already, it is divided into 4 stages: stage 1A, 1B, 2A, 2B, 3A, 3B. There are 4 stages, right? So let us see all those 4 stages right now. So as I told already, formula feeding is a risk factor, low growth is a risk factor, prematurity is a risk factor for IUGR. And pathophysiology mainly includes the intestinal microbiota because of the increased sensitivity of the intestinal wall to the bacteria. They will try to evade the defense, and as a result of which it produces disease. Okay, so which one? Intestinal microbiota. Clinical features, as I told you already, first one is feeding intolerance. The child used to vomit after eating everything. The child may have abdominal distension, along with other manifestations like abdominal tenderness, small palpable nodes, etc. So, what are all the manifestations of Bell staging? Stage 1 is characterized by lethargy, temperature instability, apnea, and abdominal distension. The first and foremost important point that should be given importance in a suspected case of necrotizing enterocolitis, apart from feeding intolerance, abdominal distension should be gained importance. Second one is so stage 1. Stage 2 is characterized by focal nematosis and diffuse nematosis intestinalis. Nematosis intestinalis means air that is present in the intestinal lumen. So what is called, in case of stage 2A, the nematosis intestinalis started, and in stage 2B, the nematosis intestinalis worsens. Intestinalis worsen. At advanced stage, these bulla will destroy, okay, will be destroyed and leading on to pneumoperitoneum. What? Leading on to pneumoperitoneum. Peritoneum. Remember, what is the treatment of choice? Anaerobe. Anaerobe means two important antibiotic. One is vancomycin, another is metronidazole. One is vancomycin and another is metronidazole. Vancomycin can be given orally, not IV, to act on the intestinal anaerobes. So apart from antibiotic, you can do a minimal surgery and you can drain the pus. You can drain the pus, but an absolute indication, what is the absolute indication for surgical opening? The absolute indication for surgical opening is dash. What? Opening is stage 3C. What? Stage 3C, in which there is rupture of the peritoneum. First, stage 3A is pneumoperitoneum. Third B is rupture of the peritoneum. So what are all the treatment offer apart from NEEPR oral IV fluids? You can offer ventilatory support if the child is sick. What are all the surgical correction for this observed? Okay, what are all the surgical correction? The only indication for surgical correction is dash. What? Perforation of the intestine. Prophylaxis, look here, necrotizing enterocolitis, even though it is sepsis mediated, it is prevented by giving, okay, antenatal steroids. I repeat, antenatal steroids will reduce not only your necrotizing enterocolitis, but also your respiratory distress syndrome, but also your respiratory system syndrome, and but also it closes your PDA. So breastfeeding should be taught. Probiotics can be given. So what are all the salient features of necrotizing enterocolitis? Let us revise it fastly. So let me write only key points. So what are all the key points? It occurs in preterm. The predisposing factors are bottle feeding, non-breastfeeding. Okay, one is preterm, second one is reduced intestinal blood flow. Okay, what are all the triad of presentation? Abdominal distension. One is abdominal distension, second one is stool for occult blood. Third one is feeding intolerance. Third one is feeding intolerance. Third one. So what is that staging called as? That staging is called modified Bell stage. that modify. What are all the three stages? 1 AB, 2 AB, 3 AB. Okay, 3 AB. So what are all the other MCQs? They will ask you nematosis intestinalis, when it started. Nematosis intestinalis, when it was started. Okay, in stage 2A. Another MCQ. What is the absolute indication of surgery? Pneumoperitoneum. Absolute indication of study, pneumoperitoneum. Absolute indication for surgery is pneumoperitoneum. So with this you need to build up. With this you need to build up your own thing. Okay, so this is all about necrotizing enterocolitis. Management, as I told you, oral vancomycin, oral metronidazole. Oral metronidazole can be prevented by giving antenatal steroids as well as breastfeeding. Antenatal steroids as well as breastfeeding. Right. Breastfeeding. Now, the question is respiratory distress syndrome. So, what is this respiratory distress syndrome? Okay, get ready now. Only two things you need to know with respect to respiratory distress syndrome. You must be knowing that majority of children who develops distress immediately after birth, they must be having some surfactant problem. It is not so. It can be a medical problem. It can be a surgical problem. Particularly the surfactant related island membrane disease usually presents in preterm who are not given any surfactant. Okay, even then, this respiratory distress syndrome is usually managed by giving a simple positive pressure ventilation in the form of continuous positive airway pressure CPAP. Only when the CPAP is fails, they will try other things like a surfactant. Okay, right now. So, what are all the things we are going to discuss in case of respiratory distress? Respiratory distress. So, let me explain it first. Okay, let me add here. 1 second. Let me add here. Okay. So, what are all the parameters by which you will find out whether the child is having respiratory distress? So, respiratory distress means the parameter is rate. What is the respiratory rate? Second one is retraction. Just in drawing is there or not? Rate, retraction. Third one is air entry. Third one is air entry. Fourth one is cyanosis. Okay, wow. Fifth one is okay, rate retractions, air entry, cyanosis. And then what else you have? So what is this called? This is called Downey score. This is called Downey. The fourth last one is grunting. Last one is grunting. So this is Downey score is rate retractions, air entry, cyanosis, and grunting. And you will be giving a score of 0, 1, 2. You will be giving a score of 0, 1, 2. So what is the importance of this Downey score? Downey score, you can identify whether the child having mild respiratory distress, moderate respiratory distress, or severe respiratory distress based on this Downey score. Based on this Downey score. So what is the what is the value of Downey score? Downey score minimum 5 into 0 equal to 0. Maximum 5 into 2 equal to 10. 5 into 2 equal to 10. So this is minimal scoring. This is maximal scoring. Downey score. Okay, so again you can have 0 to 3 or 4 to 7 or 7 to 10. Sir, what is the 0 to 3, 4 to 7 and 7 to 10? 0 to 3 means mild. 4 to 7 means moderate. 7 to 10 means severe respiratory distress. So mild respiratory distress, moderate respiratory distress, and severe respiratory distress mainly in the form of What is the score? Downey score 0 to 3, 4 to 7, and 7 to 10. This is called Downey score. Remember, 0 to 3 oxygen alone is enough. Moderate 4 to 7 continuous positive airway pressure. Third one is severe, you need to give mechanical ventilation. You need to give mechanical ventilation. So this is how by just calculating the Downey score, you can manage the child accordingly. So 0 to 3 means oxygen, 3 to 7 means CPAP, and more than 7 to 10 means it is usually severe respiratory distress, and the child has to be mechanically ventilated. Mechanically ventilated. So this is mechanically ventilated. Okay, so right now we have seen once again, so Downey score we have seen. Right. So what are all the other things that can lead to this respiratory distress? What are all the things? One is congenital pneumonia. Second one is surgical causes like a congenital lobar emphysema, congenital diaphragmatic hernia. These are all the symptoms can predispose the child for hyaline membrane disease. Okay, remember one more thing. So RDS, hyaline membrane disease, mainly is concerned with the respiratory distress in a preterm newborn that occurs as a result of respiratory distress because of surfactant deficiency. What? Surfactant deficiency. Okay, you all know that surfactant is produced by type 2 alveolar epithelial cells. Type 2 alveolar epithelial cells. Its production begins by 20 weeks and ends by 35 weeks. Okay, production increases by type 2 alveolar cells. Type 2, this is another question. Type 2 alveolar cells usually produces surfactant, and it gets produced by 20 weeks, but it gets maturation only after 37. 30, again, I'm sorry, by about 35 weeks. Okay, right. Next. Pathophysiology, very very simple. Whenever you have hyaline membrane disease, the hyaline will coat the inside surface of the alveoli, as a result of which you cannot do any, as a result of which the hypoxia occurs, as a result of which hypoxia occurs. Again, this alveolar damage can lead to hyaline membrane inside the alveoli, inside the alveoli. Okay, what are all the clinical features of respiratory distress? As I told already, not only in your UG period, this Downey score of rate retraction, arenary grunting, cyanosis is present in each and every corner of the thing. Okay, so clinical features. What are all the clinical features? Rate retraction, arenary grunting, and then cyanosis. Any child, it doesn't mean that a newborn, any child, if it comes with the respiratory distress, you can use this scoring system of Downey's without mentioning it. But as far as the discussion is concerned, Downey score is mainly meant for term babies with respect to respiratory distress. Is there any other scoring system? Is there any other scoring system for preterm babies? So Anderson, Silverman Anderson. Another scoring system is called Anderson Silverman scoring system. Silverman scoring system. This is for whom? This is for preterm child. This is for preterm. Anderson Silver scoring system. This is for preterm child. So rate retraction, cyanosis, and then what is the X-ray picture of a hyaline membrane disease? So if you don't have any surfactant, I repeat, if you don't have any surfactant, surfactant is the one which distance the alveoli. When you don't have surfactant, your alveoli gets compressed, leading on to expulsion of air and every fluid that is present in the alveoli, as a result of which the whole lung will be collapsed, and otherwise it is known as small volume lung. Remember, it is small volume whiteout lung. Not only whiteout, it is called small volume whiteout lung. There are so many causes for respiratory distress, but the only one that causes but the only one that causes low volume for low volume rather than high volume. Small volume whiteout lung is, unless otherwise proved, is dash. What is this? Hyaline membrane disease. Okay. What is the treatment? As I told you already, very, 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 very important right now. So listen carefully, my dear boys and girls. What is the treatment for hyaline membrane disease? Please listen to me carefully. What is the treatment for hyaline membrane disease? So let me write three things. The three things are DAX. What is that? DAX. Listen carefully. What is that DAX? D stands for Downey score. A stands for presence or absence of apnea. X stands for X-ray changes. X-ray changes. So remember, if the Downey score is less than 3, if there is no apnea, if there is no X-ray findings, simple CPAP is sufficient. Simple CPAP is sufficient, which can distend the alveoli. CPAP. So remember, my dear friend. Remember, my dear friend. Not all cases of, I repeat, not all cases of hyaline membrane disease will be requiring surfactant, even though it is born preterm, even though it lacks surfactant. The one particular thing, this hyaline membrane disease can also be treated by a simple CPAP, pressurized oxygen that keeps the alveoli distended during expiration, that is PEEP. So when the Downey score, case 1, when the Downey score is less than 3, without apnea, without X-ray, CPAP is sufficient. But when the Downey score between 4 to 7, when the Downey score between 4 to 7 without apnea and with some ground glass GGO picture, then you can start, you can do ensure. What is called ensure? What is called ensure? Ensure means intubate. Ensure means intubate. Surfactant administration and extubate. Intubate, surfactant administration and extubate. Any child with hyaline membrane disease or respiratory distress, stage 1 CPAP, stage 2 ensure. Ensure means intubate, put surfactant, take the intubation again out. So the purpose of intubation here is only to administer surfactant and not for respiratory support. But when the Apgar is more than 7 by 10, or in the presence of apnea, or when you have small whiteout lung, we are dealing with a case of, okay, hyaline membrane disease, that too severe, as a result of which you need to put the baby on mechanical ventilation along with surfactant, along with surfactant surfactant. So remember, this is very, very important. Whether Downey score is how much, whether apnea is present or not. Third one is, what are all the X-ray findings? X-ray findings. This is all about management of hyaline membrane disease with the help of surfactant. With the help of surfactant. Then comes, how will you manage surfactant? What is the way to prevent? Hyaline membrane disease? Again, the answer is very, very easy. Or what is the way to prevent hyaline membrane disease? The answer is very, very easy. Prevent. One is antenatal steroids. Steroids. So remember, what are all the two methods by which you will give antenatal steroids? One is betamethasone, which is long acting, that can be given once daily for 48 hours. Once daily for 48 hours. I repeat, hyaline membrane disease can be prevented by giving antenatal steroids, and it can be treated by giving the betamethasone once daily. Okay, betamethasone once daily for about 2 days. Okay, one more steroid is dexamethasone. One more steroid is dexamethasone that has to be given 12 milligram. So this is 24 milligram. So this is 12 milligram two times daily into 48 hours. So it comes one and the same. So it comes again one and the same. So you are giving 4 doses. You are giving not fourth hourly, 4 doses. 2 days. Four, not fourth hourly, 4 doses. 4 doses. So each dose 12 milligram into 4 doses equal to again it comes around 24 milligram. So first one is I'm extremely sorry. I'm extremely sorry. So beta methasone is extremely okay. So beta methasone, dexamethasone. Beta methasone you give 12 milligram 24 hours apart. 12 milligram 24 hours apart. Okay, apart. So 2 doses. So 12 plus 24 milligram. Whereas dexamethasone 6 milligram 12 hourly. So for 48 hours means it comes around 4 doses. Again it comes around 24 milligram. So the total dosage that you need to cover, is 24 milligram, either long acting beta methasone once daily 12 milligram or short acting dexamethasone 6 milligram every 12 hourly for about 48 hours to cover again that 24 milligram. Again one more beautiful point, this antenatal steroids, I repeat, this antenatal steroids prevents hyaline membrane disease. It prevents what previously we saw, it prevents one more thing, retinopathy of prematurity, it prevents necrotizing enterocolitis, and it also prevents sepsis to some extent. Which one? Antenatal steroid. What is the only contraindication? Very, very, very important. The only contraindication for antenatal steroids is foul smelling liquor. Foul smelling liquor is the contraindication to antenatal steroids, because the child after giving steroids may develop chorioamnionitis. So this is an absolute contraindication. Fetal sepsis or foul smelling liquor is an absolute contraindication for antenatal steroid. Rest of them are not an contraindication. You can start right early. In fact, apart from hyaline membrane disease, your retinopathy of prematurity, necrotizing enterocolitis, and sepsis will be decreased to a very great extent after steroids. Okay. Then now one more beautiful point I would like to discuss. What are all the beautiful points that I would like to discuss? Remember, what is the role of surfactant? Surfactant is produced at 20 weeks and gets matured by about 37 weeks. Any child who is born less than 37 weeks will be requiring surfactant. It is not so, as I told you already. When you have a respiratory distress of mild respiratory distress along with without any apnea or without any x-ray changes, the child has to be started on CPAP. Now the question comes, how do you analyze that the surfactant has undergone maturity? I repeat, that the surfactant has undergone maturity to say that the child is eligible for a normal delivery. Because if the surfactant has not attained maturity, you can give steroid, you can give steroid and you can postpone the delivery for about a week. So I forgot to tell you one more beautiful point is, you have started giving surfactant, how long you need to wait? So remember, you have started giving surfactant and the child should be born minimally 24 hours later after giving surfactant. 24 hours later after giving surfactant, and this antenatal steroid effect will be there up to 7 days after surfactant. Up to 7 days after giving surfactant. So rule of one, we need to minimally 1 day to postpone the delivery after giving steroids, and the delivery should occur with before 7 days after giving steroids to have a benefit of the antenatal steroids. This is another important point. So now how to find out the maturity of the surfactant? The answer is very simple. So lecithin sphingomyelin ratio of more than 2.1. Lecithin sphingomyelin ratio are of more than 2.1. Second one is 2:1. Presence of phosphatidyl glycerol itself. Remember, both lecithin and sphingomyelin is present in the surfactant from 20 weeks. But as the age progresses, lecithin will increase and sphingomyelin will decrease. As a result of which, increased lecithin sphingomyelin ratio can be taken into account for maturity, or to say that the surfactant has undergone maturity. But as far as the phosphatidyl glycerol is concerned, the presence of phosphatidyl glycerol itself is an indicator of lung maturity. Again, these are all the two common things that people will ask, that a lamellar body count with the help of microscopy no one is doing, and foam stability test. This is a very, very important short note. So what is called, and also this question can be asked in your Viva OC. So remember what is called foam test. Foam test means take the laker and then you need to shake. When you have foam, it means that the surfactant has attained maturity. When you don't have foam, the surfactant doesn't have any maturity. And the final point is surfactant albumin ratio. When the surfactant albumin ratio, higher the ratio means more the maturity of the surfactant. More the maturity of the surfactant. So maturity of the surfactant. So what are all the possible questions? Again, a small revision. What are all the possible questions that they will ask you? Possible questions they will ask you with respect to hyaline membrane disease. One is CPAP for mild, for moderate score of 5 to 7. You can give insure. What is called insure? Intubate, surfactant and extubate. Third one is mechanical ventilation in the presence of apnea or in the presence of whiteout small lung. What are all the benefits of antenatal steroids? Benefits of antenatal steroids. Then they will ask you what is the course and dosage of steroids. Fourth, what is the contraindication of antenatal steroids? 5. What are all the tests to find out the maturity of the surfactant? You need to write less than sphingomyelin ratio more than 2:1, presence of phosphatidyl glycerol, presence of surfactant albumin ratio, higher the ratio, foam solubility test, presence of foam after shaking. Okay, and then lamellar body count, which we usually don't do. So these are all the potential questions that can be asked with respect to hyaline membrane disease. In hyaline membrane disease, they will ask you one, treatment of antenatal steroid schedule. Two, how to manage hyaline membrane disease. Two, third one is how to identify the maturity of the surfactant. How to identify the maturity of the surfactant. Maturity of the surfactant. Right. So this question is over. These are all the things you need to write. Things you need to write. Okay. Apart from that, okay, one second. What are all the surgical causes? They will ask you what are all the surgical causes. They will ask you what are all the surgical causes for respiratory distress. This is again a short notes. One, point number one, first surgical cause, frothing from mouth indicates tracheoesophageal fistula. Second, an infant with respiratory distress and scaphoid abdomen. Scaphoid abdomen is congenital diaphragmatic hernia. Third one, An infant with on mechanical ventilation suddenly develops distress and air entry is reduced. What is this? This is called pneumothorax. Pneumothorax. Again, a well appearing infant with minimal distress and air entry absent on the left upper lobe. What is this? This is called congenital lobar emphysema. Emphysema. So these are all the surgical case causes for neonatal respiratory distress. These are all the surgical causes for neonatal respiratory distress. Apart from that, this question can be asked. What is this question? Approach to respiratory distress. Let me write. Approach to respiratory distress. Please watch carefully. So whenever any child is brought with respiratory distress based on either Downey score or Silverman Anderson says score, you need to divide the child into whether it is a preterm or whether it is a term So again you need to divide preterm and term into whether it is a well baby, whether it is a well baby or whether it is a sick baby, whether it is a well baby or whether it is a sick baby. Okay, one more point is, one second, whether it occurs less than 6 hours, or it occurs more than 6 hours. Less than 6 hours in preterm and term is different. More than 6 hours in preterm and term, the cause is one and the same. What are all the two causes for neonatal respiratory distress in preterm and term which occurs after 6 hours? So one is if the child is in shock, then it is sepsis. If the child has got hepatomegaly and cardiomegaly, the child is said to be in congenital heart disease. So congenital heart disease and sepsis is the most common cause for respiratory distress in children more than 6 hours, whether it is a preterm or term. And then in preterm, less than 6 hours, what are all the causes? One very few. What are all the causes? Preterm means you all know, one is hyaline membrane disease, second one is hypothermia. One is hyaline membrane disease, second one is hypothermia. Membrane disease, second one is hypothermia. Less than 6 hours in case of term can be divided into two things. Whether it is a well baby or whether it is a sick baby. Well baby means it is transient tachypnea of newborn, or it can be due to polycythemia, whereas sick baby means it can be either due to meconium aspiration syndrome or it can be due to meconium aspiration syndrome. Okay, less than 6 hours in term baby meconium aspiration syndrome, or it can be HIE stage 2. Why HIE stage 2 produces respiratory distress? Yesterday class we saw that stage 2 is nothing but parasympathetic activity. So when parasympathetic activity increases, respiratory secretions increases, leading on to respiratory distress. Beta, this respiratory distress approach is again a very important short notes or long notes based on which you need to build up. Right. So next question. What is the next question? Infant of diabetic mother. So what are all the things that you need to know in infant of diabetic mother? Very simple. Infant of diabetic mother is a very famous short notes and also a long notes. So just find the following points. Infant of diabetic mothers, they are prone for seizures immediately after birth. So less than 6 hours means think about hypoglycemia. Less than 6 hours means think about hypoglycemia. Again, seizures. Infant of diabetic mother, more than 6 hours means hypocalcemia. More than 6 hours mean hypocalcemia. The child is more prone for sudden death in the third trimester. The child is prone for Sudden death in third trimester. Sudden death in third trimester. The child at the time of birth is prone for shoulder dystocia. So shoulder dystocia and prone for humerus fracture as well as clavicle fracture. Clavicle fracture. Okay. Then the most common cyanotic congenital heart disease in infant of diabetic mother. Most common acyanotic congenital heart disease. Next one is most common specific congenital heart disease. That is congenital heart disease that is specific to infant of diabetic mother. Most common congenital heart disease is cyanotic congenital heart disease. Is what is that? TGA, transposition of great arteries. Most common acyanotic congenital heart disease is I'm sorry VST is okay VST. Most common specific congenital heart disease is asymmetric septal hypertrophy. Asymmetric septal hypertrophy. Hypertrophy, and then the child can go for delayed passage of meconium. Delayed passage of meconium. Delayed passage means not able to pass meconium even 48 hours after birth. So this delayed passage of meconium, what is that? Any specific condition? What is the specific condition? The enteric nervous system stops at splenic flexure. Stops at splenic flexure. It won't go beyond that. As a result of which, you will get something called lazy left colon syndrome. What is that? Lazy left colon syndrome. People will be asking you why the child of infant of diabetic mother is not passing stool, means it is lazy left colon syndrome. In lazy left colon syndrome, what will happen? The enteric nervous system will not develop beyond splenic flexion. And finally, it is prone for hyaline membrane disease. Normally, hyaline membrane disease occurs in a preterm, but when it occurs in a term, think about infant of diabetic mother, because insulin antagonizes, mother's insulin antagonizes, okay, your surfactant. That's why lecithin sphingomyelin ratio in infant of diabetic mother, instead of being more than 2:1, it should be more than 3.5:1 to say it has attained maturity. To say it has attained maturity. And also, whenever any child is born, think about they are more prone to hairy pinna. What pinna? Hairy pinna. Any child if has got so much of hairs in the pinna, you should think that the mother has suffered from diabetes mellitus during the third trimester. So what are all the things? And last point, they are large for dead babies. They are large for dead babies. Why they are large for dead babies? Because insulin is an anabolic hormone. Insulin is the anabolic. That's why it increases the growth of each and every tissue. Since it increases the growth of each and every tissue, it increases RBC production, leading to polycythemia. Polycythemia. So this polycythemia in turn causes hyperbilirubinemia. In turn causes hyperbilirubinemia, jaundice. And this polycythemia will also cause increased viscosity, leading to renal vein thrombosis. Leading to renal vein thrombosis. Leading to renal vein thrombosis. This one, so this one is this particular page is very very important for what? IDM, infant of diabetic. Remember, what is the normal lecithin sphingomyelin ratio? Maturity more than 2:1. But infant of diabetic mother, it is more than 3.5:1. It should be more than 3.5:1. 3.5 is to 1, right? Okay. Right. The last topic for today is jaundice. Okay, part of today's section is on jaundice. Today's section is on jaundice. So let me explain something. Section is jaundice. Remember, whenever someone speaks about jaundice, every people will be afraid, oh, the child is having jaundice. It is not so. Because in children, jaundice is always pathological, but in newborn baby, jaundice is physiological. Why jaundice is physiological in newborn baby? The answer is very simple. Why jaundice is physiological in a newborn baby? The answer is very simple. So there is something called physiological jaundice in newborn. Why? Because increased RBC turnover. Turnover. The normal RBC turnover. The normal lifespan of RBC is 120. But in case of term baby, it is 90 days. In case of term babies. In case of preterm baby, it is 60 days. So more and more RBC turnover leading to more and more bilirubin production leading to jaundice. 1. 2. Reduced glucuronide transferase. Reduced glucuronide transferase enzyme. Transferase enzyme, so that only when the bilirubin is conjugated, it will be converted into water soluble bilirubin. Anything that is water soluble can be excreted in urine. If glucuronide transferase is not there, uh, bilirubin cannot be converted into water soluble product, as a result of which it cannot be excreted, leading on to increased jaundice. Third one is reduced Y ligandin. What is this Y ligandin? Y ligandin is a receptor protein that is present in the liver, which causes uptake of bilirubin that is bound to the albumin. Bilirubin that is bound to the albumin. So these are all the causes for physiological jaundice. But remember, how do you say it is called physiological jaundice? Remember, the jaundice never ever on first day. Very, very important. Physiological jaundice never ever on day one. On day one. Very, very important. Physiological jaundice. Second point, never ever causes. Never ever causes okay, more than 14 days. So it doesn't happen in the first day, it doesn't happen after 14 days. So usually between 2 days to 14 days. And remember, never involves palms and soles. The uterus never involves palms and soles. Involves palms and soles. Which one? Your physiological jaundice never involves palms and soles. Never your serum bilirubin. Serum bilirubin crosses more than 20 milligram per deciliter, usually 14 milligram per deciliter. 14 milligram per deciliter. So you need to know what is called physiological jaundice. You need to know what is called physiological jaundice. Second point, you need to know what are all the characters of physiological jaundice. But there are some causes for exaggerated physiological jaundice. What? Exaggerated physiological jaundice. Exaggerated physiological jaundice. That means it can go beyond 2 weeks, beyond 14 days, but will never ever cause any kernicterus. What are all the causes? One is breast feeding jaundice. What is called breastfeeding jaundice? Remember, more and more you take breast milk, the faster will be the intestinal transit time. You all know that bilirubin will be excreted into the intestine. When there is a faster intestinal transit time, the bilirubin that is excreted into the intestinal tract will go out. But when the food intake is not good, your breastfeeding is not good, your intestinal transit time becomes slower. So the bilirubin that is excreted into the intestinal lumen will tend to be there in the lumen for a longer time and undergoes enterohepatic circulation, leading on to increased exaggerated jaundice. So what is the treatment for breastfeeding jaundice? More and more feed you need to give to reduce the breastfeeding jaundice. So breastfeeding jaundice means you need to remember enterohepatic circulation. Second point is increased breastfeeding. That is the treatment of choice. Second one is what is called breast milk jaundice. What is called breast milk jaundice? Jaundice, pregnanidiol. I repeat, pregnanidiol. That is present in the breast milk with inhibit conjugation, as a result of which sometimes even breast milk feeding it can lead to prolonged jaundice, but here it is usually not ominous. So please don't stop breast milk even it is a breast milk jaundice. Third one, what is the third one? Third one is again if there is a pyloric stenosis. So reduced intestinal transit time leading to increased enterohepatic circulation. Fourth one is hypothyroidism. Fourth one is hypothyroidism. Okay, so these things can contribute to exaggerated physiological jaundice. Exaggerated, and then I'm sorry, concealed hemorrhage, cephalometoma. Concealed hemorrhage. Hemorrhage, cephalometoma, all these things can cause us exaggerated physiological jaundice. So you need to know what is physiological jaundice, what are all the characteristic of physiological jaundice, why physiological jaundice occurs, what is called exaggerated physiological jaundice, in which condition this exaggerated physiological jaundice occurs. Okay, then what is called pathological jaundice? What is called pathological jaundice? What is called pathological jaundice? One, and one more beautiful point I forget to tell you. What is that? Always it is indirect hemoglobin. Always it is indirect bilirubin. Your direct bilirubin will be less than 20% of total bilirubin. Your direct bilirubin will be less than 20% of total bilirubin in case of physiological jaundice. Then what is called pathological jaundice? What is called pathological jaundice? One, jaundice on day one. Sorry, let's write in some other. What is called pathological jaundice? So what is called pathological jaundice? Very simple. Jaundice on day 1. 2. Jaundice that crosses more than 14 days. 3. Jaundice that involves palms and soles. Involves palms and soles. 3. 4. Jaundice that is associated with kernicterus, that is involvement of basal ganglia. Involvement day 1, day 14, palms and soles, kernicterus. These are all patholo. And remember one more point, direct bilirubin more than 20% of total bilirubin. So this, when the direct bilirubin is more than 20% of total bilirubin, and if lasts for more than 14 days, what we call it as neonatal cholestasis. What will we will call it as neonatal cholestasis. Neonatal cholestasis. Which one? Pathological jaundice. Okay, physiological jaundice. What are all the causes for pathological jaundice? One is Rh incompatibility. Second one is ABO incompatibility. Third one, G6PD deficiency. Fourth one, it can be due to hereditary spherocytosis. Hereditary spherocytosis, G6PD deficiency. Okay, so what else? So there are so many things that can cause hemolysis in newborn. Okay, what are all the other things? Let's see. So G6PD, hereditary hemothyroid. So all these things can cause pathological jaundice. Then you need to know something called Kramer staging. What is called Kramer staging? Remember, my dear boys and girls, Kramer staging is nothing but, see, either you can measure the extent of jaundice by measuring serum bilirubin with the help of blood, or else like an infrared thermometer, you have an infrared meter to measure the jaundice that is present in the body without taking serum bilirubin. That is another thing. But it doesn't mean that you need to prove objectively each and every time. You can have a subjective version of measurement of serum bilirubin. What is that subjective measurement? That is called modified Kramer scale. So what does it mean? Whenever you want to see whether any jaundice is there or not, you need to keep the thumb over that part. Okay, apply pressure for about 3 seconds and take it. Look for yellowish discoloration. So if yellowish discoloration is present in face alone, it indicates that the serum bilirubin is 4 to 6. If yellowish discoloration is present in chest and abdomen, it means the bilirubin is 5 to 10. If it is present in lower abdomen and thigh, the bilirubin is 12 to 14. If it is present in arms and lower limbs, the bilirubin is 15 to 18. And remember one point, bilirubin of palms and soles means it is always more than 20 milligram per deciliter. This is called Kramer visual assessment of icterus, and based on which you can assess an indirect evaluation of serum bilirubin, because icterus usually proceeds in cephalocaudal direction. So chest means less than 5. Bilirubin involving palms and soles means serum bilirubin is more than 20 milligram per deciliter. So icterus usually spreads or progresses in cephalocaudal direction. Remember, like pallor, you need to find the scleral icterus in a good daylight. Scleral icterus in a good daylight. I told you with the help of an infrared thermometer, bilirubinometer, you can measure. That is otherwise called as transcutaneous bilirubinometer. But what the more common questions will be asked on modified Kramer staging, which depends on the visual assessment of the icterus and based on which serum bilirubin is calculated indirectly. Right? Okay, then what else? So assessment of jaundice. And then whenever you have indirect bilirubin, and if it is more than 20 milligram per deciliter, invariably you need to start the child on phototherapy. You need to start the child on phototherapy if the child is stable. If the child is not stable and showing signs of kernicterus, if the child is not stable and showing signs of kernicterus in the form of shrill cry or incessant cry, you don't have any time to start phototherapy. So jaundice involving palms and sole, indirect hyperbilirubinemia, signs of kernicterus means you can directly go for exchange double volume transfusion. Exchange double volume transfusion with O negative blood. Exchange double volume transfusion with O negative blood. O negative blood. This is again an important question for you. Okay, O negative blood. Right. So treatment for indirect, as far as treatment for direct jaundice is concerned, it is different. So indirect jaundice means icterus involving palms and soles, child is stable, serum bilirubin more than 20 milligram per deciliter, phototherapy can be given. But if the child is sick, signs of kernicterus, jaundice is rapidly progressing, then you can do exchange, double volume exchange transfusion with the O negative blood, right? Okay. So kernicterus, as I told you already, indirect bilirubin is lipid soluble, so it will reach the basal ganglia, leading to basal ganglia damage. The manifestations are shrill cry, hypertonia, opisthotonus, etc. Opisthotonus, etc. So what else? So this is with respect to indirect hyperbilirubinemia. This is with respect to indirect hyperbilirubinemia. As far as direct hyperbilirubinemia, as far as direct or otherwise known as neonatal cholestasis. Neonatal cholestasis. What is neonatal cholestasis? Direct bilirubin more than 20% of total bilirubin. One. Second point is jaundice lasting for more than 14 days. So in this scenario, you divide the child into two, well baby and then sick baby. Well baby means it is extrahepatic biliary atresia, surgical condition, or choledochal cyst, surgical condition. Surgical condition. Choledochal cyst should be excised. Whereas extrahepatic biliary atresia, liver transplantation should be done. But before liver transplantation, there is a procedure called Kasai procedure, gastroduodenostomy, okay, jejunostomy, Kasai pressure that should be done within 3 months before the onset of cirrhosis. But when the child is sick, it comes under neonatal hepatitis. Neonatal hepatitis. It can be due to torch infection. It can be due to inborn errors of metabolism. These are all the things with respect to indirect, direct or neonatal cholestasis or neonatal cholestasis. Okay, so what else? Inborn errors of metabolism, two main things. One is galactosemia, second one is tyrosinemia. These two things will cause indirect, these two things will cause liver failure and direct hyperbilirubinemia. And as I told you already, prolonged jaundice in newborn, more than 3 weeks, breast milk jaundice, breastfeeding jaundice, cephalometoma, G6PD deficiency, pyloric stenosis, everything was discussed. Treatment I have discussed, never ever stop breastfeeding even in cases with breast milk jaundice. Even though the pregnanediol in the breast milk produces jaundice, continue breast milk, nothing will happen. There is no rule of sunlight. People used to say keep your baby under the sunlight, but phototherapy is the rule. Emergency in case of exchange, in case of indirect hyperbilirubinemia, exchange transfusion is the rule. Is the rule, and they have given certain criteria. So based on the gestational age, based on the bilirubin value, you need to decide whether you need to give phototherapy or exchange transfusion. Phototherapy or exchange transfusion. And one more point, what is this scoring system? What is this scoring system? Again, this is also very simple. Again, this is also very simple. When you have a child with a high risk preterm or a child with a sepsis, even for their very low bilirubin level, you will start phototherapy. For a child with a term baby without any risk factors like sepsis or birth asphyxia, this child can tolerate higher bilirubin value. So that what does it mean? Risk assessment and bilirubin value. Higher the risk, for lower level of serum bilirubin, you start phototherapy. Lower the risk term baby, the child can tolerate higher bilirubin. So start phototherapy. You can allow the baby to have higher bilirubin values without much damage to the brain or basal ganglia. So physiological jaundice, why it had occurred, everything was discussed. Everything was discussed, and finally today's session will end with phototherapy. You all know that Phototherapy is mainly meant for. Next question. Phototherapy is mainly meant for indirect hyperbilirubinemia, not for direct hyperbilirubinemia. Okay. So remember, a mother of O negative blood, O mother. So come with icterus. He was treated promptly with the help of phototherapy. Discuss phototherapy in short term and explain the mechanism of action. So remember, phototherapy mainly the levels are based on whether it is a term baby without a high risk factor, a preterm without a high risk, a term with high risk. High risk means G6PD deficiency, sepsis, hypothermia, etc. Or a preterm with a high risk factor. With high risk. Remember, this comes under low. This comes under, so this child, term baby without any risk factors, can tolerate high bilirubin. Can tolerate high bilirubin. Whereas preterm with preterm with the risk factors will not tolerate. So start phototherapy even at low bilirubin values. Okay, right. Phototherapy is a procedure in which the unconjugated bilirubin is converted into soluble isomer so that it can be excreted through urine and feces. What is the light you are going to use? You are going to use blue-green light with a wavelength of 460 to 490 nanometer. This is the effective wavelength. And very important question is, what are all the three types of mechanism? What are all the three types of mechanism? One is configurational isomerization, in which Z bilirubin is converted into E bilirubin. E forms isomers, but this is slowly excreted. So this configurational isomerization of Z to E is not a major mechanism of action of phototherapy. The second one is structural isomerization, in which bilirubin is converted into lumirubin. Remember, this lumirubin will be rapidly excreted in the urine, and this is the most common manifestation by which phototherapy works. Which one? Structural isomerization. Structural isomerization is what? Bilirubin is converted, insoluble bilirubin is converted into soluble lumirubin. And finally, photooxidation. Photooxidation, usually it is very minor mechanism of contribution, right? So what are all the ways by which you can give phototherapy? Either chlorofluorocarbons. Right now it is replaced by LED, and now we are using fiber optic blankets. Okay. In lights, usually we use blue lights. LED, as I told you, is preferably being increasingly used because of its durability and high irradiation. So what is the minimum phototherapy dosage that should be used? Ideal wavelength is 480 plus or minus 10 nanometer. Ideal irradiant surface is more than 30 micro watts per square centimeter per nanometer. Usual length between the phototherapy and the child will be 40 centimeter. Very important. 40 centimeter. Optimal room temperature as for delivery it is 25 degrees Celsius. 25 degree Celsius. Remember, you need to check the temperature for every 2 to 4 hours because it can produce hyperthermia. So usually with phototherapy, gradually the serum bilirubin falls. Gradually the serum bilirubin will fall. So this is all about phototherapy. This is all about phototherapy. So phototherapy means, what are all the bigger points you need to know? Configurational, structural, photooxidation. Most common thing is structural. What is the distance? 40 centimeter. What is the irradiation? More than 35 micro units per meter square. Okay. And then what is the question? What is the ideal room temperature? 25 degrees Celsius. Okay, that's all about phototherapy. Phototherapy is mainly meant for indirect bilirubinemia, not for direct bilirubinemia. direct bilirubin. And finally, with this, we have only 4 minutes. In this 4 minutes, what are all the things? Essential brief newborn care. I don't think you need to know much. Clean hands, clean surface, clean blade, clean card, clean card tie. This is very, very important. Definitely in Viva OC, they will ask you what are all the 5 cleans. One is hand, second one is surface, third one is blade, fourth one is card, fifth one is clean tie. That's all. What is the ideal delivery room temperature? 25 degrees Celsius. What is called delayed cord clamping? Yesterday class we taught you. So it is clamping the cord 30 seconds after the birth. This is called delayed cord clamping, so that anemia will not occur. Delayed cord clamping, and it also associated with reduced intraventricular hemorrhage. The only place where you can't do delayed cord clamping is birth asphyxia, because in birth asphyxia you need to start your resuscitation as early as possible. You can't wait for 30 seconds. And finally, cord should be clamped 2 to 3 centimeter away from the abdomen. Breastfeeding as early as possible, and all child should be given a vitamin K injection of 0.1 milligram to prevent classic hemorrhagic disease of newborn, because your breast milk does not contain adequate vitamin A as well as vitamin D. That's why you need to give vitamin D supplement to all exclusively breastfeeding infants. So with this, we are finishing our topic for today. So neonatology is over. Almost many neonatology topics are over. If at all some topics are left, another hypoglycemia, hypocalcemia. So those are all the little bit topics. So next week, Wednesday, Thursday, Friday is our session. We will be finishing almost 60 to 70% of pediatrics in this month itself. Thanks for your patient listening. Keep sharing about this lecture, that link to your friends also, so that they will be gaining and they will get good marks in their final year examination.